Hello, everyone. Thank you so much for joining us today. We'll just give everyone a few moments to join and then we will get started. Okay, perfect. Hello, and welcome. Thank you so much for joining us today. My name is Caitlin Mitchell, and I have the privilege of managing the WHO UNFPA SRHR-UHC Learning by Sharing portal. For those of you joining us from the Northern Hemisphere, we are heading into autumn with shorter days and cooler temperatures. For our friends in the South, spring is arriving with longer days and warmer weather. Wherever you are joining from, you're experiencing a change in seasons, and hopefully, with that, a renewed sense of energy. You will need it for our discussion today. Before we begin, I would like to share some important housekeeping information. Next slide, please. First, we will be providing interpretation in French, Spanish, and Portuguese. To utilize the interpretation feature, please read and follow the instructions on the interpretation slide. We will also be recording today's webinar. The recording will be available on the WHO HRP YouTube channel and on the Learning by Sharing portal afterward. Now that we have addressed logistics, let's turn our attention to the purpose of today's gathering. Next slide, please. As we come together online, heads of state are preparing for the upcoming general debate of the 80th session of the United Nations General Assembly in New York, under the theme Better Together 80 Years and More for Peace, Development, and Human Rights. In line with these global discussions, the WHO-UNFPA SRHR-UHC Learning by Sharing portal, or simply the LSP going forward, along with DSW, is pleased to co-host this important virtual event on sustainable financing for sexual and reproductive health and rights. This webinar will present evidence from DSW's 2025 Donors Delivering for SRHR report, highlighting that Global Official Development Assistance, or ODA for short, for sexual and reproductive health and rights has been declining for years, long before the recent cuts that occurred earlier this year, and as a result, threatening progress towards universal access and deepening inequalities, especially affecting women and girls worldwide. You will also have the chance to hear concrete examples that emphasize the importance of sustainable financing for improving access to services, supporting the health workforce, and engaging communities. We will explore strategies such as increasing domestic funding, reallocating resources, and aligning external aid with national priorities. Today's session offers a vital opportunity to reflect, to strategize, and to take action on how we can address the critical issue of declining global sexual and reproductive health and rights funding, which threatens to undo decades of progress and impacts millions of lives. Our incredible, diverse panel of researchers, advocates, policymakers, grassroots leaders, and health economists will share their insights based on the evidence, the impact of current trends, innovative approaches, and highlight where we are now, where we need to go, and what tools and solutions we need along the way. There are approximately 4.3 billion people of reproductive age around the world who, during their lives, will likely lack access to at least one essential sexual and reproductive health service. I am one of them, and so too are many of you, and they are counting on us, all of us, to act. It's time to regain momentum and ensure that no life is lost or left behind due to this preventable barrier. It's time for countries across the globe to reaffirm their commitments and to take concrete actions to protect and advance sexual and reproductive health and rights for everyone. Because as we know, investing in SRHR not only saves lives, but also contributes to healthier, more equitable, and resilient societies, ultimately benefiting individuals, families, communities, and nations alike. Throughout today's discussion, We will explore strategies to increase domestic funding, reallocate resources, and build innovative partnerships that go beyond traditional aid. We will also continue to emphasize the importance of political will and strong commitments in ensuring sustainable financing at all levels. We are here today because we believe that change is possible. We understand that collaboration, shared knowledge, and collective action are our strongest tools. We invite your insights, your strategies, and your solutions. This is a shared effort, and none of us can do this alone. Every single one of your voice matters, so let's join our hands and our minds and get started. With that, I encourage everyone to participate actively, to ask questions, to share ideas, to engage with our speakers, and to engage with one another. Together, let's learn, identify what can be adapted or scaled, and chart a path forward to a future where everyone has access to the services and support that they need. Thank you again for being here with us today. Without further ado, I would like to introduce our moderator for today's conversation, Dr. Shakira Chinara, an award-winning independent public health practitioner. Her notable accolades include being named the 2017 Woman of the Year in Health in South Africa and being a 100 Most Influential Young African. Dr. Chinara holds over 10 years of experience spanning academia, civil society, and within several United Nations agencies. She is widely recognized for her work on universal health coverage, gender equality, sexual and reproductive health and rights, and youth development. One of Dr. Chinara's current roles is to advance gender equality and sport through serving as a bold South Africa Special Advisor for Youth, Advocacy, SRHR, and Sport for Development. She is also a Lancet Commissioner on Adolescent Health and Well-Being. Dr. Chinara held notable roles, including serving in the African Union Youth Council and as an international board member of Amref Health Africa. Without further ado, Shakira, over to you.
Thank you so much for such a warm welcome, Caitlin. And it's wonderful to be checking into this webinar, which is hosted by the Sexual and Reproductive Health and Rights and Universal Health Coverage Learning by Sharing portal, which is hosted by the World Health Organization, UNFPA, and also in collaboration with DSW today. I see a whopping 219 participants and growing who are joining us for the next hour and a half. And we set to have a really exciting and important discussion on the margins of the United Nations General Assembly. As the world focuses on non-communicable diseases and mental health, we know that many parts of global health, including global health infrastructure, as well as universal health coverage, and importantly, sexual and reproductive health and rights are under attack. The topic for today's discussion is securing the future of SRHR, preserving its progress, and driving sustainable financing. I'm pleased to be your moderator today. I'm coming in from sunny Johannesburg, South Africa. As Caitlin mentioned, we do have interpretation in French and Spanish. I also wanted to mention and ask for your patience as we have a wonderful and powerful community leader and voice coming through, which will be in Hindi or Marathi later in the discussion. Again, I already see the chat box is on fire, so continue to introduce yourselves, share your resources, share your thoughts, and also ask your questions. We will certainly take questions towards the end of the discussion at least. As we go from housekeeping into the main discussion, as Caitlin mentioned, we're focusing on the donors delivering for SRHR report. And for those of you who have read it, and for those of you who will hear more about it, essentially one of the things that stands out is that in 2022, looking at 32 donors globally, only about 6% of ODA, official development assistance, has been allocated to sexual and reproductive health and rights. But in 2023, we see a decline of financing for SRHR from 6% to about 4%. And as we know, given the current circumstances, this has probably lessened. We're also finding major disruptions, again, to programming, especially HIV programming, putting the global progress and the end AIDS by 2030 at severe risk. And also, as Caitlin mentioned, all of this has implications for women and girls' access to sexual and reproductive health care. That's close to half of the world's population, but also key and vulnerable populations, those who live in LGBTQI communities, migrants, people with disabilities. So for us to really jump into the framing of what's the evidence, and again, the donor delivery report, we've got two excellent speakers. The first is Nitya George, who's a health systems researcher. Nitya is also responsible for curating this flagship report, which we'll go through. And she's joined by Dr. Elizabeth Sully from the Guttmacher Institute, who's the Director of International Research. Dr. Sully specifically leads work on various elements of sexual and reproductive health and rights, including family planning, abortion estimates, and all of this work feeds into shaping policy and investment. And if I may say so myself, Dr. Sully, I've used a lot of Guttmacher's work in the many policy, the many policy frameworks and environments that we've worked in. So without further ado, I'm going to hand over to Nitya and Dr. Sully for a 10-minute presentation, a synopsis of where we are in terms of the funding landscape for sexual and reproductive health and rights. Again, a warm welcome to many of our esteemed panelists. As we go through the discussion, I will certainly introduce all of you. Over to you, Nitya and Dr. Saleh.
Thank you so much, Shakira. I hope I'm audible. I'm happy to kick off this discussion today. Thank you to everyone for being here to have this very important conversation with us. I'll start by presenting some key findings from this year's Donors Delivering for SRHR report. If we could have the first slide. The next slide, please. Yes, thank you. So Caitlin and Shakira have already done a wonderful job of setting the context for us, so I will touch upon this very briefly. But to summarize, we find ourselves in the middle of a shifting development aid landscape and a very strong backlash against women's rights, which threatens to reverse decades of hard-won progress for SRHR. We realized in the process of developing this year's report that 7 out of the 10 champion donors that we found in our analysis this year have since announced substantial ODA cuts, which is also certainly a cause for alarm in terms of SRHR funding. In short, what we hope to do with conversations like this is understand how we in the research and CSO community can evolve our advocacy and research within this changing landscape, how the global donor community and domestic resource mobilization can step forward to fill some of these funding gaps, and of course, how global majority governments can better protect themselves and health outcomes against fluctuations in development assistance. Could I have the next slide, please? Thank you. So the Donors Delivering Report is an annual ODA tracking exercise that DSW has been engaged in for several years now. We find that tracking ODA is critical to substantiating our advocacy efforts with hard evidence and data to guide decision-making and resource allocation, to drive accountability among donors, and really assess how their policy commitments to SRHR align with their financial commitments to SRHR, and of course, to understand critical gaps in funding. Just a small note that there is a QR code at the bottom left of each of these slides if you'd like to refer to the Donors Delivering report, or we'd be happy to share in the chat and email. Could I have the next slide, please? Thank you. Just to very quickly go through the methodology of the Donors Delivering report. This analysis uses data on ODA spending from 32 members of the OECD DAC, that's the Development Assistance Committee. This is publicly available data from the OECD Data Explorer, and we look at how donors disperse their ODA under specific CRS or purpose codes. And in this process, we capture both bilateral and multilateral funding. The SRHR funding tracking methodology is unique to the Donors Delivering Report and aims to capture the full breadth of SRHR as defined by the Guttmacher-Lancet Commission. In addition, we also do report on disbursements to FP, family planning, and RMNCH using existing methodologies. This year's report provides data on 2023 OECD numbers, which is the latest data set that's available on the OECD Data Explorer, as well as some preliminary data available for 2024. Before we go into the findings, I just want to give a quick disclaimer that to a certain degree, fluctuations in annual funding levels are normal, especially with multi-year contributions being spaced out over time. And additionally, because reporting timelines of some donors and the OECD database may not always line up, it's possible that there's some variation in the data captured as well. Could I have the next slide, please? Thank you. So on to the findings. As Shakira has already teased for us a little bit, between 2022 and 2023, there was a drop in total donor investments to SRHR. And this is so from 32 donors that we study, we saw a decrease of 27% in the funding to SRHR made available through their ODA. So in 2023, 10.8 billion USD was disbursed to SRHR funding, a drop of about 4 billion USD compared to the previous year. Interestingly, though, in this time period, about half of the 32 donors, so 17 donors, did increase their SRHR disbursements. However, a large overall decrease was reported because of a drop in spending, a substantial drop in spending from the US and the EU institutions. If we look at the box at the bottom, we see that the percentage of funding dedicated to SRHR decreased, as Shakira mentioned, to 4.3% in 2023 as compared to over 6% in the previous 2 years. This is also a function of overall ODA disbursements increasing while SRHR funding and disbursements decreased. Shockingly, just as an additional point, if we take the US disbursements out of this equation, the remaining 31 OECD donors only dedicated 2.6% of their joint ODA to SRHR. So definitely a lot of space for other donors to be stepping into the SRHR funding context. Could I have the next slide, please? Just to take a quick look at this graph to see the top spenders on SRHR in terms of absolute disbursements. So not surprisingly, bigger economies with bigger ODA budgets tend to provide larger amounts of SRHR funding and disbursements. So as you can see, the top 5 spenders in terms of absolute disbursements are the US at 5.8 billion USD, the UK at 1 billion USD, and Germany, France, and Canada at around the 500 million mark. Next slide, please. Coming back to how SRHR is prioritized within each country's ODA, we find that 7 champion donors allocated more than 5% of their ODA to SRHR in 2023. These are the US, Luxembourg, the Netherlands, UK, Iceland, Sweden, and Canada. As you can see, this ranking looks a bit different from the one that we saw on the previous page, the previous slide, sorry. This is because larger donors may rank highly on funding amounts, but not as much when we look at how they prioritize SRHR within their ODA. So for example, a donor like Germany ranks 3rd on absolute disbursements, but only 21st when it comes to how they prioritize their SRHR in their ODA. It's a similar story with France and the EU institutions, which rank higher but drop lower when it comes to relative spending on SRHR. And on the other hand, some smaller economies, which rank lower on absolute disbursements, lead the way in prioritizing SRHR, such as Luxembourg and Iceland. Could I have the next slide? This is just a final slide to tell you a bit more about the Donors Delivering Report. So in addition to the data that I've presented so far, the report also includes donor profiles for each of the 32 donors that we cover. Each of these profiles summarizes donors' SRHR and gender equality policy commitments, their future outlook where available on ODA and SRHR spending, their funding trends between 2021 and 2023 for SRHR, FP, and RMNCH, as well as impact estimates based on their FP disbursements, their disbursements to family planning. So with that, I can hand it over to my colleague, Elizabeth Sally from the Guttmacher Institute, with whom we collaborate each year to produce our FP impact estimates for each donor and across the 32 donors in our report. Could I have the next slide, please? And over to you, Beth.
Thank you, Nitya. So I'm going to talk about some of our estimates from the Donors Delivering Report on the impacts that we're seeing from the 2023 disbursements for family planning. If we can go to the next slide, that will show up. And then we wanted to sort of spend the last few minutes of the presentation reflecting on, go back one slide actually, on how much has changed since 2023. It's been a pretty fundamental shifts that have happened in the SRHR financing landscape, and to talk a little bit in the conclusion of just what are the impacts that we're starting to see or likely could see in the months and years ahead. So just in terms of what was found in the 2023 Donors Delivering Report, so for the 32 OECD DAC donors, they contributed $1.76 billion to family planning. And this in turn was estimated to enable 162 million women and couples to access modern contraceptive care, averting 50 million unintended pregnancies, and in turn saving over 40,000 lives. However, the 2023 numbers represent an $135 million reduction from the previous year, which meant that there were 12.5 million fewer women and couples that could access contraceptive care, and there were 3,000 preventable deaths that could have been averted if funding had actually remained stable at the 2022 levels. Next slide. So, as I mentioned before, the funding landscape has become increasingly precarious since 2023. The US has been the largest global donor, providing 40% of all family planning funding, and it has currently canceled all family planning foreign aid. On top of this, the Netherlands announced plans to cut its aid by up to 2/3 by 2027, and the UK has announced cuts of its aid from 0.5% to 0.3% of its GDP. Combined, these three countries provide 70% of all global donor funding for family planning, and other OECD donors have either announced or are anticipating additional foreign aid cuts. Next slide. So I want to take a minute and actually zone in on these top three donors that are funding family planning, and what does this mean in terms of on-the-ground impacts when these funds are being cut. So let's start with the United States. Our estimates show that in 2024, the $607.5 million in US family planning funding ended up serving 47 million women and couples with modern contraceptive care, averting 17 million unintended pregnancies, and ultimately preventing 34,000 maternal deaths annually. All of this has now been cut, which means for 2025, there are 47 million fewer people receiving contraceptive care around the world and 34,000 more maternal deaths anticipated this year. Here and on the slides that follow, I've included QR codes that link to our Just the Numbers reports that we've done for each of these countries, showing what is at stake with cuts to family planning as they're occurring in the United States, the UK, and the Netherlands, which I'm going to go through in turn. These reports have been released in coordination with civil society partners in each of these countries as part of an advocacy strategy really aimed at trying to figure out how to protect, if we can, these critical funds. Next slide. Let's turn to looking at the UK, where it's estimated that in 2024, there was £107 million that was going to family planning, providing 11 million women and couples with modern contraception and saving almost 4,000 lives. Here we lay out the potential scenarios of how this funding could be impacted by the overall foreign aid cuts, as we don't know specifically how SRHR and family planning are going to be cut as part of the overall foreign aid reductions. Anticipating somewhere between a 30% to a 70% decline in family planning funding means that we could see between 3.3 million to 7.7 million fewer users receiving contraceptive care annually, depending on the severity of cuts that we're going to see. Next slide. Adding to these US cuts and the projected UK cuts are also the potential cuts to Dutch family planning funding. Here, we estimate that there was 96.5 million euros that were spent in 2024 on family planning by the Dutch government. And this in turn resulted in 8.5 million women and couples accessing care, saving almost 2,800 lives. Again, we don't know yet how family planning funding specifically was cut in 2024 and 2025, but for every 10 million euro decrease in the funding from the Dutch government, it will mean that there are 880,000 fewer users accessing care around the world. These are just 3 country case studies showing what's happening to family planning funding since 2023. This includes tremendous impacts that these countries had in 2024 and what is at risk when these funds are cut. And I think most importantly, it's not just about the dollars themselves, but what those dollars translate into when it comes to health outcomes and the lives of women and girls around the world. Next slide. I think I'm going to sort of conclude with some initial thoughts, and I think the rest of this session and panel is really going to have a chance to dive into these together. And I know Nitya and I are really excited to have this conversation, because I think despite of the crisis that we know that we are all in right now when it comes to SRHR financing, we do have pathways forward. First, it's essential that we diversify funding mechanisms, integrating private sector investment, philanthropic support, and pursuing innovative funding approaches. And I think we're really, as a panel, going to have a chance to dive into some of that together. But we also need to be talking about strengthening health systems through integrated care models, employing innovative strategies to alleviate workforce shortages and expand service delivery capacity in low resource settings. And then finally, we have to enhance coordination among civil society, policymakers, donors, building stronger coalitions and developing coherent, evidence-based advocacy using robust data to drive SRHR financing. This moment really demands an unprecedented collaboration to preserve the decades of progress that we've seen in reproductive health. So with that, I'll conclude our presentation of the Donors Delivering Report and really thank DSW for their partnership in inviting Guttmacher to join and talk a little bit about some of these impact data alongside the financing data. Back to you, Shakira.
Yeah, thanks so much, Dr. Sally and Nitya as well. It's really good to have this high-level overview of the Donors Delivering for SRHR report, and I'd encourage everyone to go out and read it. And of course, we'll also share a link with the QR code again. But also, as much as it was very sobering to hear about the cuts, what's the anticipated cuts as well. But as Dr. Sally said, and Nitya as well posed a really good question for us to think about through the webinar is who else can step in? There's room to step in, and there's room to continue with our progress in sexual and reproductive health and rights. Keeping with the evidence, and because of course we're hosted by the SRHR and UHC Learning by Sharing portal, it's so important for us to think about what's the evidence out there in terms of different countries, how are different countries increasing their domestic investment, what are the good practices that we can learn from. And so I'm going to turn back to you, Caitlin, and Caitlin Mitchell from the World Health Organization, who is currently supporting the Learning by Sharing portal, but also has a long history and background in sexual and reproductive health and rights, working at UNAIDS, working on female genital mutilation and cutting. Caitlin, I'm going to turn to you to take us through some of the best practices emerging from the portal that you'd like to share during this webinar.
Thank you, Shakira. And I love that there's room. I think that's a nice takeaway. And thanks to Beth and Nitya for setting the stage and providing such a comprehensive overview of the current funding landscape and as Shakira said, the sobering impact that we have already started to observe as a result of declining ODA. Before we jump into the panel discussion, I did want to share a bit more about the Learning by Sharing portal. I also wanted to share a few concrete examples of why sustainable financing is so critical. The Learning by Sharing portal, which is developed by WHO and UNFPA, is a platform to exchange country experiences on advancing sexual and reproductive health and rights within the Universal Health Coverage Framework. A key feature is the collection of implementation stories, which serve as practical examples of how countries and communities are tackling real challenges in sexual and reproductive health and rights service delivery. Today, we're highlighting a couple of those stories. The key takeaway being that sustainable financing, especially domestic financing, is important for lasting impact. These stories remind us that financing isn't abstract, but rather that it directly shapes whether women, girls, and marginalized groups can access care. Next slide, please. The LSP implementation stories reveal common themes across context. Sustainable financing, especially domestic financing, emerges as a cross-cutting need for building and retaining the health workforce, addressing inequities and reaching marginalized groups, maintaining continuity of service delivery, and supporting community engagement. These are all pillars that sustain progress in SRHR as ODA declines. Next slide, please. Let's dive into the first story from Pakistan, which shows how innovative financing helped women in rural areas reach life-saving services. As we know, transport is a critical but often overlooked barrier to care. Punjab's public-private rural ambulance service moved millions of women and children to facilities, reducing maternal mortality and improving access. This intervention shows how locally financed solutions, backed by government commitment, can deliver large-scale results. The impact has been overwhelming. Over 3 million women were transported to health facilities, 3.5 million referrals were made to higher level hospitals, and 10,000 children received urgent care, leading to a reduction in maternal mortality of 157 per 100,000 live births in 2019, ultimately resulting in improved access, including more skilled birth attendants and faster maternal care, especially in rural areas. Next slide, please. Of course, services only work if there are health workers to deliver them. The next example we have from Ethiopia highlights why domestic financing for the health workforce is indispensable. As we know, the health workforce is the backbone of SRHR. In this example, we see that Ethiopia engaged nearly 40,000 health extension workers to expand contraceptive access for adolescents. Domestic investment ensured continuity in training, deployment, and salaries, reducing unmet need and improving equity. This shows that embedding workforce financing in national budgets is key to resilience. As a result, the unmet need for contraception reduced, with more adolescents using modern methods and fewer repeat pregnancies, while equity has improved as married adolescent girls gain greater access to reproductive health services. Next slide, please. Our next example highlights why domestic financing is crucial for service delivery during times of crises. In this case, during emergencies such as the COVID-19 pandemic. In Nepal's 15 districts, limited access to contraceptives and delivery services highlighted the urgent need for financial resources to sustain and expand healthcare interventions, specifically the provision of essential maternal health services. The emergency response, spearheaded by the Family Planning Association of Nepal and supported by adequate funding, resulted in significant achievements, with over 4,500 unintended pregnancies and 3,300 unsafe abortions averted. Lives were saved and substantial healthcare costs were saved. Proper health financing ensures the necessary resources are available to deliver vital services, reducing maternal and child mortality and preventing long-term health burdens, particularly in crisis situations. Next slide, please. Last, but certainly not least, we know that we have to utilize domestic funds to invest in communities, as communities are the heart of sustainable sexual and reproductive health and rights. Domestic financing is key to sustaining trust and community-driven initiatives. In this example, we provide an example for the foundation of ongoing collaboration and community engagement with religious leaders as SRHR champions using faith-based approaches. This approach relies on continuous support to scale up successful strategies, keep educational materials updated, and maintain long-term partnerships. Without sustainable funding, these efforts risk being short-lived, making it difficult to achieve lasting behavioral change and improve access to reproductive health services for women. As a result, more women were able to seek antenatal and postnatal care, skilled birth attendants, and family planning options. Long-term financial stability ensures that progress in transforming societal attitudes and removing barriers to SRHR can be sustained and expanded over time. Next slide, please. Overall, these implementation stories highlight that innovation, whether through transport, digital health, or community engagement, need reliable financing to scale up and to sustain the impact that we have spoken about today. A clear message running through all of these stories is the importance of domestic financing, especially as ODA declines. Without embedding SRHR into national budgets, progress remains very fragile. And with that, I will now hand it back over to Shakira to kick off our panel discussion. Thank you very much.
Thanks so much, Caitlin, and also to Dr. Sally and Nitya as well for framing this discussion and providing the evidence. Caitlin, you've specifically touched on various interventions, how they're effective in strengthening sexual and reproductive health and rights, but also the health system itself, as well as thinking about what are the interventions which are working, whether it's working with religious communities or religious leaders, or even ambulance services, the health workforce, which require investments going forward. Before we jump into the panel discussion, we're having incredible audience interaction and engagement actually. We're seeing the chat box quite full. There's actually a comment from Ethiopia. I believe it's Adeba who says that it's not only about funding, but also thinking about yes, the money is important, but once the money is invested, the access to SRHR in specific countries still remains a problem. There's a specific question linked to the Delivering for Donors report or the Donors Delivering for SRHR report. I don't know if Nitya, you would like to answer it, or Dr. Sally, either way. The question is, does the report also present the impact of these reductions on countries in the South, particularly African countries, which are very affected by the funding situation? So either of you can unmute and give us a quick response before we jump into the panel discussion.
Sure, I'm happy to answer that quickly. Thank you, I think, Jessica, for that question. Yes, the impact numbers of family planning disbursements do include impact on global majority countries, including African countries, because the estimates are based on how financing creates impacts across all LMICs, so low and middle income countries. And that's how the data set is positioned, and that's how the Guttmacher FP impact calculator produces the estimates as well.
Thanks for responding to the questions, Nitya. Sorry, Dr. Sally, do you want to jump in as well?
I was just going to add, for some of the donor countries too, there's clearer data on like what countries funding was going to. And so I think it gets to this sort of the importance of having good financing data for accountability and understanding where money was going, especially when funding is being cut. So for some, like the US, we have really clear estimates of like exactly what amounts of funding were being allocated to what countries. And so how impacts are going to sort of be disproportionately then felt across countries.
Thanks, Dr. Sally and Nitya. And what a fantastic question, because it will take us to later in the discussion. Is this the sort of information that we use to lobby our governments to increase their financing? We're now going to shift into the panel discussion, and we've got an excellent lineup of panelists from those who serve at the World Health Organization, UNFPA, the Brazil Ministry of Health, community-based organizations, and again, DSW and Guttmacher, part of the panel discussion as well. It's with great pleasure that I welcome Dr. Mariana Pereira, who's the General Coordinator for Women's Health at the Ministry of Health in Brazil. She's actually a nurse by training and has specialized in public health. She's contributed in various ways to sexual and reproductive health and rights, including at a state and municipal level, working on women, children, and adolescent health in Brazil. Dr. Mariana, welcome. I hope that I'm audible and you can hear me. I understand that you'll be sharing with us the different perspectives based on your work, your experiences in the Brazilian Ministry of Health, in terms of what we need to think about when it comes to progress on sexual and reproductive health and rights, but also sustainable financing and making sure that SRHR is a top priority issue within budgets, and also delivering on SRHR. So over to you, and we didn't get to meet in the practice session, so I hope that you're here and you're able to join us. I believe Dr. Mariana may also speak in Portuguese, so you're welcome to enable your interpretation if you haven't done so already. Over to you, Dr. Mariana, if you're able to hear us.
Bom dia a todas e todos. É uma honra estar aqui nesse painel sobre o financiamento sustentável da saúde sexual e reprodutiva. Um tema muito importante, muito caro para nós do Brasil. E uma honra também ouvir os outros países e compreender as diferenças, as nuances, as diferenças e as potências de cada país. Vocês me escutam bem? Posso continuar? Ok. Bom, no que tange aos principais marcos do financiamento da saúde sexual e reprodutiva no Brasil, ao longo das últimas décadas, o Brasil acumulou marcos importantes na construção das políticas públicas voltadas para mulheres. A tradução está funcionando? Posso continuar? Aqui deu um barulho no áudio. Ok.
Dr. Mariana, I am going to step in if that's okay. I think we can all hear you. The audio I am experiencing through the interpretation channel for English is very, very low. So I don't know if the English interpreter is able to up the volume, and I don't know if that's the same for all other channels, but confirming we can hear you, and sorry.
Ok. Posso seguir?
Okay.
Much better.
Okay, confirming it's much better now.
Ok. Então, o Brasil, ao longo das últimas décadas, acumulou marcos importantes nas construções das políticas públicas voltadas à saúde da mulher, tendo seu financiamento sempre atrelado ao nosso sistema de saúde pública, o SUS, que é universal, equânime e integral em seus princípios, embora ainda enfrente desafios para sua implementação, como o seu subfinanciamento. Então, dentro do Ministério da Saúde, a coordenação que eu estou à frente, a Coordenação Geral de Atenção à Saúde das Mulheres, tem um papel central nesse processo. Um exemplo concreto desse papel é o Programa Permanente de Distribuição dos Contraceptivos, coordenado junto com a ciência farmacêutica, aqui do Ministério da Saúde também, que garante a compra centralizada dos insumos e a oferta em todos os territórios nacionais. O SUS oferece um amplo leque de métodos contraceptivos. Nós oferecemos os injetáveis mensais e trimestrais, as pílulas combinadas, a minipílula, o dispositivo intrauterino de cobre, a pílula do dia seguinte, os preservativos internos e externos e também os métodos definitivos, como a laqueadura e a vasectomia. Mais recentemente, a gente teve um grande avanço com a incorporação do implante subdérmico liberador de etonogestrel, cuja sua implementação está em fase inicial, com foco na formação dos profissionais de atenção primária à saúde, que serão as pessoas, tanto médicos quanto enfermeiros, que poderão levar as mulheres e meninas de todo o Brasil a tecnologia do implante subdérmico. A nossa perspectiva é oferecer até o final de 2026 1,8 milhões de implantes para as meninas e mulheres de 14 a 49 anos, o que representa um investimento de cerca de 250 milhões de reais. Outro marco importante para o Brasil foi a incorporação da contracepção no programa Farmácia Popular a partir de junho de 2023. O Ministério, então, passou a garantir a gratuidade da pílula anticoncepcional nas farmácias credenciadas. São farmácias privadas que têm um incentivo público para oferecer insumos estratégicos, como é o caso, né? Então, como eu já falei, da pílula anticoncepcional e também dos absorventes menstruais. E com isso, a gente consegue ampliar o acesso a esses insumos e também reforçar a autonomia reprodutiva para as mulheres. O orçamento do programa da Farmácia Popular para 2025, no que tange aos contraceptivos, é de 4,2 bilhões de reais. Nós temos um histórico robusto de políticas públicas, né, na área da saúde das mulheres. Já em 1984, a gente teve o lançamento do Programa de Atenção Integral à Saúde das Mulheres, e esse programa ele traz, então, um rompimento com a ideia das mulheres apenas como mãe, passando a reconhecer os seus direitos sexuais e reprodutivos. Em 2004, a Política Nacional de Atenção à Saúde das Mulheres se consolidou, não mais como um programa, mas sim como uma política mais robusta, promovendo os avanços, então, para os diversos eixos do cuidado à saúde das mulheres, tanto do pré-natal, na prevenção ginecológica, quanto atenção aos cânceres, quanto a questão da saúde sexual e reprodutiva, trazendo, então, uma abordagem integral à saúde das mulheres. No que tange ao planejamento estratégico federal, principalmente atrelado aos nossos instrumentos de planejamento, como o Plano Plurianual e a Política Nacional de Saúde, que são mecanismos de pactuação interfederativa e de controle das ações e iniciativas, esses dois mecanismos de monitoramento têm metas bem explícitas quanto à ampliação da contracepção de longa duração. Temos uma meta de atingir 82,5% de cobertura na atenção primária da contracepção de longa duração até o final de 2025. Além disso, o Brasil prevê uma cooperação internacional com o Fundo das Populações para as Nações Unidas no valor de mais de 14 milhões de reais até o final de 2026. Essas ações previstas nesse projeto são essencialmente para o fortalecimento da saúde sexual e reprodutiva na atenção primária à saúde, que é o foco da nossa atuação quando a gente fala de contracepção, educação em saúde sexual e reprodutiva e também acompanhamento das gestantes, das puérperas e toda a vida reprodutiva e sexual das mulheres e meninas. Quando a gente fala de equidade, vou voltar a falar um pouco do Programa de Proteção e Promoção à Saúde Menstrual. Desde 2023, os absorventes são distribuídos gratuitamente via farmácia popular. Então, isso tem um impacto direto na vida de milhões de pessoas no Brasil que vivem em situação de pobreza menstrual. A maioria dessas pessoas são negras, né, e pardas. E um exemplo concreto da alocação dos recursos é esse recorte, então, para garantir equidade e mais acesso para as meninas e mulheres que estão em situação de pobreza menstrual. Bom, eu não sei se há um interesse em trocar as perguntas, senão eu vou seguir nas perguntas que a gente se propôs a fazer. No que tange, então, as medidas para promover o financiamento equitativo da saúde sexual e reprodutiva, há um reconhecimento de que, historicamente, os recursos destinados à saúde da mulher no Brasil privilegiaram a saúde materna e infantil, inclusive a nossa política de saúde das mulheres na década de 40 estava atrelada a um departamento de saúde infantil, então foi um grande avanço, né, nesses últimos 100 anos praticamente, em que a gente consegue resgatar a centralidade das políticas de saúde das mulheres, não só vinculadas ao cuidado das crianças, né, mas avançando para além disso, mas ainda assim a gente sabe que existe um forte investimento na saúde materna e infantil. Então, corrigir essas distorções é um compromisso dessa gestão atual do Ministério da Saúde. E, nesse sentido, algumas ações são importantes para serem destacadas. Em relação ao planejamento reprodutivo, o Ministério da Saúde tem investido no acesso aos métodos de contracepção de longa duração, como o DIU implante. Também está em andamento a publicação de novos manuais e a criação de centros de referência para a formação e multiplicação das ações de contracepções por profissionais através, né, dos contraceptivos de longa duração, com apoio do Fundo das Populações para Nações Unidas também. É uma parceria que nós já estamos consolidadas em 6 estados brasileiros. Essa parceria e essa estratégia é fundamental para reduzir a gravidez indesejada e ampliar a autonomia reprodutiva das mulheres. Na perspectiva da equidade étnico-racial e territorial, uma iniciativa importante também que vem sendo desenvolvida pelo Ministério da Saúde, se chama Rede Aline. Rede Aline é o nome da rede materna e infantil do Ministério da Saúde, que homenageia Aline Pimentel, que foi uma vítima de violência obstétrica e do racismo estrutural no sistema de saúde, em que o Brasil, inclusive, foi acusado de violação de direitos humanos na Corte Interamericana de Direitos Humanos e também na CEDAW, e, portanto, o Brasil responde a essa ação, trazendo para a centralidade da discussão o tema da saúde materna e infantil com um emblema do nome da Aline Pimentel. Bom, a Rede Aline busca, então, enfrentar essas desigualdades raciais e regionais, assegurando que todos os municípios recebam recursos para qualificar sua rede de atenção. Também está previsto, né, a criação de um protocolo intercultural para emergências obstétricas com foco na população indígenas e diretrizes específicas para os cuidados obstétricos de mulheres negras e indígenas. Por fim, o tema do aborto legal, o foco tem sido na qualificação dos serviços existentes.
Dr. Mariana, if I may interject, you are sharing extremely interesting insights, and we'd love for you to continue, but I'd like to ask if you kindly wrap up in about a minute or two, if that's fine.
Certo, estou finalizando. Por fim, no tema do aborto legal, o nosso foco para a qualificação desse tema tem sido a qualificação dos serviços já existentes e também a previsão de aquisição do dispositivo de aspiração intrauterina, né, que é um instrumento fundamental para a garantia da assistência humanizada e segura no pós-aborto. Por fim, então, trazendo um pouco do papel das evidências dos dados no financiamento das políticas de saúde sexuais e reprodutivas, eu queria dizer que o Brasil tem orientado o seu financiamento em saúde através das evidências, né? Então, eu já trouxe os mecanismos de pactuação e de planejamento do SUS, que é baseado em diagnósticos epidemiológicos e demográficos. Então, para planejamento das políticas públicas, a gente utiliza esses instrumentos. E, além disso...
That's fantastic, Dr. Mariana. Thank you so much for sharing this overview of really, the coverage that Brazil has, the planning, the data, which is pushing implementation. It really is so exciting. And I do apologize for interrupting you, as I'm cognizant of the time and us moving along. But again, it's really painting a picture for us of what the future can look like if governments invest wholeheartedly into sexual and reproductive health and rights. You've shared how addressing the bias is important, but also addressing various elements of SRHR, including menstrual health and hygiene. So thank you for joining us, and we will return back to you with questions as well. I'm now going to shift the panel discussion to thinking about what's happening in low and middle income settings as many LMICs are grappling with funding cuts, and what are we doing to support these LMICs? For this, I'm going to turn to Dr. Bruno Misen, who is a senior health financing advisor at the World Health Organization. He joined WHO Financing and Economics Department in 2020, holding over 20 years of experience in academia and 6 years in humanitarian aid. Bruno, you're very well known for your work on economics, health sector reform, but also knowledge management. Welcome to the panel discussion, and over to you to take us through what are WHO's efforts in supporting LMICs to navigate this really difficult financing landscape and context that we find ourselves in.
Thanks, Shakira. Yes, well, that's situation is difficult. That's very clear. It's not specific to any group of conditions or diseases. All of us, countries and actors, we are still trying to understand the developments and consequences, but some general guidance can already be shared. It's clear that in terms of volume, aid as we knew it will not come back. So everyone understood that countries have to accelerate the transition to domestic funding. New ideas are on the table, but it is essential to not to forget the knowledge we have built about how to finance UHC. There are no magic solutions. There are no magic schemes which will solve the challenge. So we have to do some essential actions. So from a health financing economic perspective, this requires specific interventions both on the revenue and on the expenditure side. On the revenue side, equitable access to services will only be guaranteed by public pool prepaid compulsory resources. Nothing new there. And on the expenditure side, maximizing health impact will require resource allocation and spending decisions informed by efficiency considerations. So countries will have both to increase the amount of public resources for health, often also through a parallel strengthening of their tax revenue collection, and to increase the efficiency and equity of health spending, for example, through more strategic purchasing. So rather than simply asking for more money, ministries of health will have to demonstrate their improving allocative and technical efficiency. This can be done by shift to primary care services, use of generics, shift in human resources practice. On PHC, we still have a challenge to go beyond rhetoric and to make meaningful shift in many countries. Something positive is that the repertoire of possible and appropriate actions is available and is valid as before. We have a global practice of more than 30 years of thinking and working on health financing systems with a strong consensus among global experts. So I believe the health financing community, including WHO, is well equipped to support member states and their partners in navigating the health financing emergency. But it's clear that operational challenges are huge, and consequences for population are a source of major concern for us. And this was very clear from the presentation earlier in the webinar. Yeah, I will stop here at this stage. Shakira.
Bruno, thanks so much for, highlighting that the knowledge that we have is so important, and keeping with you because that knowledge is so important that we actually protect it. I know that you were involved last year with the NCD dialogues around sustainable financing for NCDs and mental health. And again, it's the focus of this year's United Nations General Assembly. And we don't operate in silos. So it would be very good to hear from you. What are some of the lessons that you can offer based on your work from last year, but also taking it forward?
Thanks, Shakira. Yeah, well, the situation with NCDs and mental health is not easier. They have never been a priority for the global aid community. So the second dialogue of last year was marked, I believe, by pragmatism. By that, I mean that there was this recognition that we have to really well prioritize the limited donor resources. And we had also to issue clear guidance to countries on how to leverage domestic funding and improve their health financing system. So maybe 2 points here. First, we cannot stress enough that we should not confuse funding with financing. Sometimes we are approached by colleagues and asking us to improve funding for their diseases, let's call it like that. And we try to explain them that health financing is much broader. It's about institutional arrangements which organize the key functions of resource mobilization, so funding, but also pooling, purchasing of services and benefits. The second point is that there are nothing such as health financing for NCDs or health financing for sexual and reproductive health. We cannot have each disease having its own resource mobilization or its own fund pool. It's very inefficient. Still, there is an interesting exercise, and this is what we did under the second global dialogue, is to look at health financing arrangements from the perspectives of a specific group of conditions, for instance. So, for instance, if you take purchasing, well, you can look at purchasing. Many of the things will be common across conditions, but still you may look at whether the payment create the right incentives from the perspective of NCDs, for instance, or SRH. So this is exactly what we did under the second dialogue. We brought together communities which often live in silos. So the mental health experts, NCD experts, health financing experts, we brought them together and we tried to develop guidance on really what can be done in terms of health financing and domestic funding for NCDs and mental health. So we published last week a summary of this global dialogue. I will later put it in the chat. It's a paper published in the Lancet Global Health, and that's maybe something which could be interesting for us. Actually, it would be to have some collaboration between the health financing community and the sexual and reproductive health community, and try to see what could be the way forward. We did some case studies to inform the global dialogue, and so myself, I was involved in case studies in Ghana and Ethiopia. We have tried to understand what were the barriers to domestic funding for NCDs and mental health. And maybe the main finding is that, well, it's not a major discovery, but I think it's good to remind it is that domestic funding will be mainly determined by domestic politics dynamics. So I believe as a global community, we have to pay more attention to what's going on there and how we can support emergence. And the point is, of course, to recognize that, for instance, SRH is a societal problems requiring really political action. And there is a key role for civil society organizations, I think, in terms of raising awareness and really mobilizing the citizens for the cause. I will stop here, Shakira.
Thanks so much. That's Dr. Bruno Misan from the World Health Organization. Bruno, you've raised some consciousness in myself as well. I hope I've been using the term funding and financing correctly. So that's an excellent point. Do pop a link to the Lancet articles and publications that you mentioned. It will be interesting to read. And one of the takeaways you've shared is that mental health has never been a priority, and it's been a difficult priority to push in the budget sphere. And that's one of the very key similarities to sexual and reproductive health and rights. You also touched on the role of civil society. And before I move into our wonderful speaker from the civil society space, I do want to say that we have such a huge number of questions coming through, which I'm really excited about. So I would encourage the panelists, if you look at the Q&A section, many of the questions are there. Feel free to start responding. And also in the chat box, start to respond as well. I've seen quite a number going through. And of course, at the end of the discussion, we will continue to take these questions. It's with great pleasure for me to introduce Kiran Deshmukh. Kiran is from Vaishya Anyay Mukti Parishad, VAMP. This is the name of the organization. Kiran is a community activist. She's also part, if she is the correct pronoun, is part of the AIDS, a collective of sex workers in India. She has over 17 years of experiences. She's influenced national policies, international work commissions, and UN bodies as well. Kiran will be speaking in Hindi or Marathi, I believe. So I do ask for your patience. She is sitting with a live interpreter, so she will be speaking in her preferred language, and will then hear the interpreter. This won't work via the interpretation function, I believe. Kieran and your colleague, if you're able to hear us, the questions we'd like to know from you, and it's really interesting because your work with VAMP have taken a decision to move away from traditional donor funding mechanisms to alternative funding strategies. Could you take us through what that is, and also what are the challenges in trying to do this?
नमस्कार सर्वांना. संग्राम आणि वेश्यान्याय मुक्ती परिषद सांगली महाराष्ट्र कडून मी किरण. मी स्वतः सेक्स वर्कर आहे. फंडिंग खूप महत्त्वाचे आहे. फंडिंग गरजेचे नाही हे आम्हाला मान्य नाही. जेव्हा पूर्वी डोनर्सनं त्यांची धोरणं ठरवून फंडिंग देणं बंद केलं, तेव्हा व्हॅम्पनं स्वतःची संसाधनं वापरून व्हॅम्प संघटनेला टिकवून ठेवण्यात आम्ही यशस्वी झालो. उदाहरणार्थ बघा ना, भारत सरकार मोफत कंडोम वाटप करतं आणि आमचं काम सुरू ठेवण्यासाठी आम्ही मोफत कंडोमवर खूप अवलंबून आहेत. HIV, STI पासून मुक्त राहण्यासाठी आम्ही निरोगी राहण्यासाठी आणि लैंगिक सेवा देणारे म्हणून काम करण्यासाठी आम्हाला कंडोमची अत्यंत आवश्यकता आहे. परंतु सरकारकडून हा मोफत कंडोम पुरवठा बंद झाला की ते मिळवण्यात आम्हाला वेळोवेळी काही आव्हानं येतात. अशा परिस्थितीत व्हॅम्प संघटना एकत्रितरित्या सामूहिक पैसे गोळा करते आणि व्हॅम्पचे लीडर्स कंडोम विक्रेत्याकडे जातात. सर्वोत्तम किंमत ठरवून ते कंडोम वाटण्याकरिता खरेदी करतात. मग असा निष्कर्ष काढला का की कंडोमची गरज आहे, पण कंडोम मिळाले नाही तर आपण कशा प्रकारे कंडोम देतो? आम्हाला माहित आहे, आमचं जीवन आणि काम कंडोमच्या योग्य वापरावर अवलंबून आहे. लैंगिक सेवा पुरवणारे आणि गिराईक सुरक्षित आहे याची खात्री करणं खूप आवश्यक आहे. आम्ही आमचं काम अशा प्रकारे सुरू ठेवलंय. शिवाय एक मजबूत संघटना म्हणून एकत्रित राहणं हे अतिशय महत्त्वाचं. स्थानिक गुन्हेगारी टोळ्या आणि लैंगिक कामगारांवरील हिंसाचार हे केवळ एक मजबूत संघटना उभारूनच हाताळू जाऊ शकते. आमच्याकडे प्युअर एज्युकेशन कार्यक्रम आहे, पण आम्हाला त्यांना देण्यासाठी निधी मिळाला नाही. तर आमच्या प्युअर एज्युकेशन कार्यक्रमाला थोडंसं नुकसान होईल, कारण आमच्यातील प्युअर हे गरीब आहेत आणि जर आम्ही त्यांना थोडे पैसे दिलं तर ते कंडोम वाटण्यास मदत करतात. परंतु जरी आम्हाला पैसे मिळाले नाहीत आणि निधी पूर्णपणे बंद झाला तरीही आम्ही अशा प्रकारचं काम करून आमची उपजीविका, आमची संघटना जिवंत ठेवू शकतो. कारण संघटनेचं महत्त्व असं आहे की पोलिसांशी, हिंसाचाराशी काही समस्या असली तर आमची संघटना समस्या सोडवण्यास मदत करते. म्हणून निधी असो वा नसो, आम्ही संघटना आणि संघटनेद्वारे आमचा कार्यक्रम जिवंत ठेवला आहे.
Translation in English. I'm Kiran from Sangli, Maharashtra, India. Thank you, Shakira, to answer your question. Funding is necessary. We do not accept that funding is not needed. But in the past, when funding was withdrawn due to donor policies, we managed to sustain the WAMP collective by pooling our own resources. For instance, the Indian government provides condoms for free, and we are dependent on free condoms to continue our work, sex work. We need condoms to be free from HIV, from STI, and to continue to live healthy and work as sexual service providers. But we periodically have faced some challenges in accessing free condoms when the supply from government is stopped. In such cases, the WAMP collective pools money. Its leaders go to wholesale dealers, negotiate the best possible prices, and buy condoms for distribution. So why did we come to the conclusion that condoms are needed, but if condoms are not provided, we provide condoms in this way? We know that our lives and work depends on the proper use of condoms. We need to ensure that the service provider and the clients are safe. And hence, we have continued to work in this way. Besides, it's very important for us to stay together as a strong collective. Local criminal gangs and violence against sex workers can only be dealt with by building a strong collective. Lastly, we have a peer education program. If we do not get funding to pay them, our peer program will suffer a little because peers are very poor. And if we give them a little money, it helps in distributing condoms. But even if we do not get paid and funding is completely stopped, we can still keep our livelihood and our collective alive by doing business using these strategies. Because the importance of the collective is that if there is any problem with the police, violence, or health, the collective helps to keep the community together and resolve the issue. Therefore, whether there is funding or not, we have kept the collective alive and the program alive through the collective. Thank you.
Thank you so much for sharing, Kiran. One, also sharing about what's the implications of the diminishing funding landscape. How would life continue without access to condoms, for example, and the type of work that's being done, but then also sharing the importance of pooling resources, which BAMP is doing. So congratulations on that work and for sharing it with us as well. We're now going to turn to Dr. Jan Lekke, who's the Family Planning Technical Global Lead at the United Nations Population Fund, UNFPA. He's a medical doctor and a health economist, also contributed to UNFPA's family planning strategy. We've heard so much about family planning already, the funding cuts, the implications as well. But Dr. Jan has been behind programmatic tools used in over 80 countries. Dr. Jan, welcome. We'd like to really ask you to give us some insights into the UNFPA Supplies Partnership, which is such an exciting model because UNFPA has moved away from a traditional aid model to a co-financing approach like the Compact. So how is this working? How is it increasing domestic family investment in family planning, and then also turning to the models which the incentive uses, such as the match fund. So over to you to really take us through learning the how, the why, the impact, and the experiences.
Thank you, Shakira, and good morning, good afternoon, everyone, and good evening. My name is Jan Lekke. I'm a family planning advisor and financing technical lead for the Supplies Partnership. So let me share a bit about the Supplies Partnership and what we do. The UNFPA Supplies Partnership Program. It's in the third phase now. It's been running since 2007. Our main job is to make sure that low and middle income countries have access to reproductive health commodities and particularly contraceptives. Well, we provide technical support and we facilitate procurement of reproductive health commodities, among other, many important elements that would help strengthen health systems. So I just wanted to make that reference since now, with the current context, UNFPA supplies became the largest and most important reproductive health commodities procurement since the defunding of USAID, and that puts things, I believe, in different perspective, right? So when you mention on your question, Shakira, that how this model has evolved over years, I would say we had to adapt to the shifting landscape, and I really don't like to talk about shifting landscape. I've been working in financing for development and SRHR for the last 25 years, and I never heard a single year where we were not experiencing financial crisis. So we've been in a financial crisis almost forever. The difference is how we take this contextual factors and respond to the needs of women and girls in the field. And I feel that, the Supplies Partnership make that very important shift in the fundamental idea of, this donor-led aid model to a co-financing and share investment model with the ultimate goal of fostering, true ownership and long-term sustainability. I think the bet on our side was to, raise that political will and materialize the political will into concrete actions. So if you think about, all the times you've heard about discussing, experts in sustainable financing, health economics about, the fiscal space constraints in these countries, I wonder how much of that is a real bottleneck compared to the political will. This is what we realize. Political will is a major driver of sustainable financing that helps materialize, that commitments into action and fulfill the needs of women and girls to access sexual and reproductive health services and family planning services. So this is where we focus. We used to tend to have this conversation in a fiscal financing space with ministers of finance. Sometimes we have access. Most of the time, reproductive health managers and key stakeholders did not have access, the capacity, the knowledge, or expertise to engage in these conversations. So that the discussion were more about, what were the needs, technical needs of reproductive health commodities, family planning services, et cetera, what was the demand. And there was somehow a disconnection between that and, the financing processes, public financial management processes, how the budgetary cycle works. So when we, in this new phase, when we removed, these, I would like to call it noise, when we remove all the financing noise from the main topic, which was political commitment, we were able to, catalyze this discussion and have, an honest and transparent discussion about the main topic. Should we prioritize SRHR and family planning as a best development investment? And even if the country didn't have the financial capacity to fulfill those needs. So that is a real conversation. And by doing that, we were able to, design an instrument that we call the Compact Agreement that helped us to materialize that political will, removing the financing elements from the moment, or for the moment, from that discussion. So the Compact Agreement is pretty much an agreement that incorporates the commitment from the Ministry of Health that understand the needs at the country level. The Ministry of Finances has the capacity to fund and finance these needs through different financial instruments and mostly through domestic resources allocation. And then UNFPA was a major procurer of reproductive health commodities, have different instruments, one that helps incentivize domestic resource mobilization, other that facilitate or maximize the efficiency in the procurement of these commodities. So I would say that the compact commitment is the key tool that turns this philosophy into action. It helped us to catalyze that political will and created the accountability piece. And that was extremely important. By including the Ministry of Health and the Ministry of Finance in the same conversation, under the same topic, under the prioritization of family planning or reproductive health commodities, rather than the capacity of financing, these needs, I think we made this problem part of their agenda, particularly the Ministry of Finance. And that was a game changer as it moves family planning from a silo health discussion to a more national development fiscal priority. So that in that way, the Compact Agreement creates a predictable cycle of commitment and review requirement governance to make annual domestic financing contributions based on the forecasting of the needs and the capacities, the fiscal capacity the country have. And also considering other key players. I mean, there are many key players, including bilateral donors, the GFF, and the Global Fund, and many other actors that are contributing towards the same goal. So I think the Compact Agreement elevated that dialogue and is currently impulsing or boosting similar conversations in different areas of the health system. In terms of your second question, I'm going to just share a quick example on the compact commitments and the political will generated. It's a good example is Madagascar. In 2022, the government signed a compact agreement And by 2024, the domestic spending on contraceptives soared to $9 million, with a commitment of $25 million for 2025. So this is an incredible trajectory and was mainly driven by the formal high-level commitment and clear accountability framework that the compact provided. Now, this is just, as I mentioned, one part of the equation. The second part of the equation is how to get there, how to assign and allocate the resources that needed to fulfill that political will, to materialize that political will, and then what would incentivize, financially speaking, that kind of decision making. So we came up with a couple of different instruments. One of them is the match fund. And the match fund is a financial incentive that adds the real teeth to the political commitment. From our view, is an innovative mechanism that rewards and maximizes a government's own investment. For every dollar, for instance, the government spends on quality assured commodities, UNFPA provides $2 worth of additional commodities. So this creates a powerful argument for the Ministry of Health to take to the Ministry of Finance as a compelling investment with a clear return. If you ask, you're not bringing a problem to your Ministry of Health, you're bringing a solution. And that solution may hopefully leverage additional resources, like in this case a match fund, but also perhaps help to unlock this first link indicator from GFF and get additional funds from the World Bank. So this is the way we see leverage of financing from the match fund. And one of the interesting cases was Nigeria, where UNFPA was able to unlock $4 million in domestic fund that had been stalled for years. The promise of the match fund was the critical lever that helped advocates to unlock that money. But all this doesn't happen just in a vacuum. These are incentives. We have also, third-party procurement mechanisms that help countries to directly access quality assured commodities, and that helps also to facilitate or maximize the procurement processes. But there is a very important catalytic element here. It is advocacy, a smart advocacy for domestic research mobilization, glued to public financial management minimum capabilities at the country level. So what we try to do with smart advocacy for domestic research mobilization is to build not only the knowledge and capacity of countries to engage across the budgetary cycle, different phases, but bringing in different stakeholders to plan ahead and advocate together to Ministry of Finance and Ministry of Health to make that happen. Just as an example, I'm wrapping up right now. After implementing smart advocacy in around 43 countries in mainly Western Central Africa and Eastern South Africa region, 74% met their minimum financing requirements last year. Just Cote d'Ivoire in this approach led to a 600% increase in government's family planning allocation. And in Ethiopia, expenditures increased fivefold in 2024 compared to 22. Combining these three key elements, the compact commitments as a political expression, then the match fund as an incentive, and then the catalyzer of the smart advocacy interventions and advocacy plans. So I'll stop here for any questions you may have. Thanks so much, Shakira.
Dr. Yen, we'd love to have you over, and I hope I'm not overstepping, but saying that, we'd love to have you over for another webinar, unpacking this a lot more by countries and regions. It's so, so interesting and really important. I would say, and sorry to put you on the hot seat, but there are many questions coming out around what can we do in conflict settings or humanitarian settings. Because we're in a race against time, I would ask that yourself and other panelists type away at the chat box to answer all of the questions, and specifically to you, Dr. Yen, based on the work of the compact, how are you seeing that play out in contexts like Afghanistan and other humanitarian settings as well. So to wrap us up, I'm going to turn back to Nitya and Dr. Elizabeth Salian. Thank you for hanging on as we listen to the different interventions. I will ask each of you to share a 30-second around the future of sustainable financing for sexual and reproductive health and rights. But as we heard from Bruno, it's not only SRHR, it's universal health coverage, it's global health. Your 30-second, very powerful message for us to begin to wrap up this panel discussion. Nitya, we'll start with you first.
Thank you, Shakira. That's a big ask. But I guess if I'm thinking about one major takeaway for me, I think is advocacy, and one of the strongest advocacy tools we have at our disposal is evidence. We have such a wealth of evidence that health and development financing is not just a cost, it's an investment. Donor countries that have invested in SRHR and health in the past have also benefited from it. We already know the numbers, like every dollar invested in comprehensive access to modern contraception results in $8 in economic returns. We have research from ODI Global and Pandemic Action Network that shows that every euro of ODA that's spent actually pays for itself 1.5 times over. So really being able to come together as a community, have some solidarity and coherence in what we're asking for. And as all of our panelists have said, kind of not framing SRHR as one of the competing priorities. We don't work in silos to make sure that we have a consolidated sort of ask for development financing and health financing going forward. And so many questions, in our chat about how to really, what does it mean for domestic financing to be stepping in, not just leave this as a kind of conceptual topic, but really be able to empower global majority governments in sort of co-owning and co-developing and making sure that the resources that we do have are being optimally used. Over to you, Beth.
I'll do less than 30 seconds because I feel like Nitya covered most of what I wanted to say. I think this idea of moving away from thinking about costs and expenditures to thinking about investments and the full scope of the return on investment for SRHR is really critical. And we have the data and evidence. A lot of that is there. I think the key thing is, how do we be more strategic and smart about how we use it? That not just sort of generating things at global levels, but having local context-driven data driven by actors in those countries, timed strategically for when decisions are being made, right? Like, it's not just having the data and having a really good case. It's being smart and strategic about how, when, and who is employing that data. And so I think it's also the advocacy strategies that have to exist alongside the evidence.
Thanks so much, Nitya and Dr. Sali. And thanks to all of our panelists. You've been so interesting that time has flown by. I wish we had even maybe an entire day or a workshop or even a conference about this issue. You know, it's so important. But a big thank you to Dr. Mariana Pereira, who's the General Coordinator for Women's Health at the Ministry of Health in Brazil. A big thank you to Dr. Bruno Meissan, who's the Senior Health Financing Advisor at WHO. Dr. Yen Leke from UNFPA, Nitya George, who came through and presented her excellent work and DSW's excellent work on delivering for SRHR through donors, Dr. Elizabeth Sali and Kieran Deckschmuth as well. We're now going to turn for closing remarks, 2 minutes of closing remarks to Dr. Ibrahim Banuru, who's the Africa Renaissance World Organization of Family Doctors. He also has a wide experience in sexual and reproductive health and rights in terms of research, in terms of supporting the government of Nigeria, and really exciting. Welcome. You're also an expert review group member for the SRHR and UHC Learning by Sharing portal. Dr. Ibrahim, over to you.
Thank you very much, Shakira, for the very wonderful introduction. It's been an insightful afternoon. Good day, dear colleagues. I'm sure we're in different time zones. It's afternoon here in Nigeria. As I sat listening this afternoon, I felt both deeply concerned and quietly hopeful. The message is clear. The progress in sexual and reproductive health and rights is dwindling. And this is not because the needs are diminished, but because funding and political will is shrinking. For those of us on the front line of services, particularly in the global south, this is not just a policy debate that we had today. It is a daily reality of stock outs, unsafe deliveries, and dreams deferred for women and girls. The evidence also reminded us that investing in SRHR is not only a smart policy, it is a multiplier for healthier, fairer, and more resilient societies. Our speakers gave us a roadmap. The WHO reminded us that there is no single solution and that countries must move towards sustainable domestic financing with reforms that deliver both equity and efficiency. The collective from Maharashtra showed us the strength of communities is very important even when donors pull back, and the power of civil society to protect rights and lives even when funding is dwindling. The God marker and DSW emphasize how data and advocacy can open policy windows and hold donors accountable. From the UNFPA, they've demonstrated how political will can translate into budget lines through compacts, match funds, and smart advocacy that we've seen in countries, including my country, Nigeria. From Brazil government, we've had it inspired us on the constitutional commitment and then innovative financing that embed SRHR into national priorities. These are important. The message today is clear. Aid will remain important, but it will not return to the past levels that we know. It's dwindling. So the future of SRHR depends on courageous choices by governments, by civil society, and by all of us working across sectors to keep sexual and reproductive health and rights central to universal health coverage. And that's what we do at the HRP-WHO. From Nigeria here, I can say that that is possible. Just this month, we held our first national health financing dialogue, where we asked very hard questions about ownership, about efficiency, and about integrating sexual and reproductive health and rights into health benefit packages of the national health insurance. That kind of conversations must happen everywhere across the globe. Dear colleagues, this is about more than closing financing gaps. It is about protecting rights, protecting dignity, and futures. Let us live here not just with commitments, but with conviction that investment in SRHR is not a cost or a charity. It is a fundamental human right. Every penny withheld puts a life at risk, and every investment secures a future. So we have a choice. Do we want to put a life at risk, or we want to secure a future? So I urge us all, dear donors, dear governments, dear civil society, global partners, and every one of us, let us be true partners in building systems that seize everyone, that carry everyone along and serve everyone for a sustainable future. Thank you for the conversation, and I hope the conversation moves forward. Thank you.
Dr. Banaru, I couldn't have summed it up better. So thank you very much, and also leaving us with the words that we need for action. Thank you again to all of our experts, our panelists. I would like to also give a specific shout out and thanks to Caitlin Mitchell, to Vilashni Govender, Bertha Swars, and the entire interpretation team who also joined us today. Thanks for tuning in to this webinar around sustainable financing for sexual and reproductive health and rights in what are increasingly challenging times. But as Dr. Yen pointed out, it's always been challenging to raise resources for SRHR. And so our fight continues until the sexual and reproductive health and rights for all populations. Do also take a look at the SRHR and UHC Learning portal, which is housed and hosted by the World Health Organization and UNFPA, and also thanking DSW and NITIA for the collaboration today and really sharing the evidence around the decline of donor funding, but also the opportunities which are there, which Dr. Sally also spoke about. With that, I thank you all for joining in, for being such an engaging audience, and we hope to see you soon.
Thank you, everyone.
Thank you so much, everyone. Wonderful to have you all here.
Thank you.
Thank you.
Thank you.
Take care. We'll go ahead and end the webinar.